So I'm about ready to tell you some very, very deep and dark secrets of the U.S. government, and I'm going to expose some conspiracies that even Joe Rogan can't fathom. And one of the things that we're going to talk about, and I'll reference actually Joe Rogan as probably one of the most culturally significant individuals that are out there now as a perfect example of the unbelievably effective propaganda and brainwashing that we now have occurring. That a guy who is so absolutely advantaged, and not advantaged in a bad way, that is earned, and that's an advantage. That's the very word is turned into a dirty word, but he's worked for those advantages and he's earned those advantages. And somebody that is so advantaged can be so unbelievably, ironically brainwashed about a certain subject, and that's where I'm going to talk about it. And I'm kind of going to use him, because I've been accused of punching down to a University of Michigan and Veterans Affairs doctor and professor who is fully backed by the United States government, and so I don't want to be punching down anymore. Of course, the key to that whole entire thing is the fact that it's she. And part of and key to this entire conspiracy that we'll be unraveling here is that exact fact. There's something in the Veterans Affairs toolbox that's called the Violence Risk Assessment Instrument. And giving all things being equal, a female reporting a male veteran is an automatic probability and potential threat against the reporting provider. Giving all things being equal, simply the genders alone on the form give the output result that the veteran has the potential for violence. So to go back into this conspiracy and how all these things work, and how Joe Rogan is unbelievably brainwashed, is using him as an example is great because he is so well versed in so many different things and he has access to so many different people. And has had these conversations and has reflected on so much of the stuff that is so important to the brainwashing of the entire population that I'm happy. I happen to be one of the only people who have their eyes open, and some bold statements, and we're going to back them up. So what is it? It is this. If you take Joe Rogan's positions on everything, from all matters, from his health regimen to the drug use to the different modalities of healthcare treatment and different things that are available, his philosophy is a pretty easily identifiable one that most people actually agree with, right? It's essentially to maximize the access to whatever might help whoever. And where the irony comes into is if you are a rational individual who can sit here and just, if we can agree, the majority of people who are prescribed opioids did not have a problem with them. We're not addicts. So if we can make that simple agreement that the majority weren't causing the problems, it would be fantastic to be able to ask what happened to those patients. But nobody asked that question. So as you take Joe Rogan's philosophy of maximizing this, you understand, you kind of see where he says, particularly when, and he obviously always disclaimers, and he's not professional, whatever else, but he's very well versed, and he has more access to more information and more resources than 99.9% of the entire world population. So if he can be brainwashed on opioids, anybody can be. So if we can agree, majority of patients did not have a problem with opioids, and that they are no longer on those opioids, is it a fair question to ask what happened to those patients? And why don't we know what happened to those patients? That's what I'm going to talk about. And why I'm talking about it and why I'm smarter about this stuff than some of the people that I'm going to be bringing into this is because the U.S. government made it a quagmire. For the last 5 years, I've been researching this and trying to understand what happened to myself in my own care. And that is why I understand what the other pieces of the puzzle that nobody else is saying and nobody else is bringing to the table. And the video that I'm going to allow play through is kind of a reaction to, and it's simply because this video just kind of recently released on a book called Policing Patients by somebody who is very well researched and understands the problem to, I would say, almost an expert level, doesn't actually understand some of the most key points and problems with it and where those gaps are. So this book leans a lot into the prescription drug monitoring program. Where my own care kind of falls apart is my care my care. So let me begin by saying I'm kind of openly helping some organizations within the harm reduction. I hate even saying the words, but space. So I'm openly helping them. I don't represent them. I know their views aren't mine. My views aren't theirs. But however, they're working on some good, important things. And where I'm coming in is that I'm the patient. I'm the patient that everybody's talking about, but apparently nobody's talking to. So that's what I'm going to do. I'm going to start talking to everybody because you guys are missing things. I'm going to explain what you're missing. And why am I qualified to do it? Is because it's been a 5-year journey to get my case before a federal judge. And so I know what it takes, and I know how I had to navigate. And I'm not saying my way was the right way, but I know what it took and how to navigate to get before a federal judge. Um, and I've worked out some permission to be able to speak about this. As what my case is a federal Privacy Act case, a records amendment case to correct a record in which I'm accused of showing up at a VA pain clinic and demanding opioids, as well as being non-compliant with several different modes of care and several other clinics within the VHA, and having dirty presumptive urinalysis labs, all of which is absolutely false. I mean, and to be able to and I'm sitting here before you all right now telling you that that is a claim the VHA made against me that is still on my record 5 years later, despite me following the entire process to get it before a judge. That's how long this takes. So a lot of the harm reduction folks are well-meaning and everything else, but there's certain things that they don't understand that is perpetuating this problem. There's certain things that folks like Joe Rogan don't understand that's perpetuating the problem. And these are the things that I'm going to explain, what I came across through trying to get my record corrected, and why what there it is. And it's the clearest way to say this is that patients who have the number one condition within the Veterans Health Administration have been criminalized. Okay, they have been criminalized. So I will walk you through kind of briefly how a patient will approach a problem within the VHA and how the process currently works or was working. If a pain patient who say is on, was on opioids or was not on opioids, doesn't matter what, is not satisfied with their pain care and they don't find their pain care treatment to be satisfactory, may report that and they may ask for a second opinion, and they may even get another provider, and they may even get a second opinion. And if that patient still doesn't agree, unlike any other condition within the VHA, they do not have a right to a clinical appeal. So that at that point, that is dead. Now, that is supposed to be very limited, solely about opioid access, right? Just a medication access. And that's where part of where these the harm reduction folks don't understand. In this video I have here, they speak near the end about how the communities need to come together and that they're a good fit. And that's where the ignorance of the law is harming or perpetuating the problem, because there's a law that's called Comprehensive Addiction Recovery Act, and that thing does a lot of things. But one of the things it does is an under crisis authority. Okay, if you think of the CARA Act as the Patriot Act of medicine, because that's what it is. All right, it's this, and it's more vile than, or I should say, the abuses. The intent obviously is good. The intent on both were good, but the abuses that the limitations on rights that were allowed by these policies and laws are given a space in which to get out of control and not necessarily have a off ramp for the people who are victims of it to actually get out of it. Okay, so, and it's very much the same mindset. And a lot of this video that they're going to talk about here covers, and that's why I want to use it as kind of a catalyst of it covers a lot of the aspects of it, but doesn't go to the level of understanding what is the bottom line, what are the keys. So, as a former bomb technician, it turns out to be a vulnerability, because within the VHA, I'm assessed as my potential for violence to be so high that they can limit my rights secretly and do all these actions against me without me being able to do anything. Now, which you can, like anything, you've done it enough and you've experienced enough, and you get that whatever 10,000 hours into wherever else, you get a different understanding of it, and sometimes it simplifies it. And so if you break things down to the basics, so like for like most bomb technicians, they'll all look at you, and when the rubber meets the road, what are we talking about? We're protecting against heat, shock, and friction. That's our concerns. Those are 3 things that matter. All right, and there's a whole lot more involved in it, but that's where the rubber meets the road. So where's the rubber meet the road on a patient's rights? Okay, where's those risk management and those diagnostic mechanisms to look at, how that works? And everybody ignores it. I mean, so how does it work? I'll tell you. So here's my story, and I'll try to do it as quickly as possible while also making sure that this isn't about me. If I didn't have to do this, if nobody else was doing this, I would much rather just disappear and just be part of my community and be very content with that. But nobody is. So what happened to me was I retired from the military with a very good treatment plan that was written out, essentially, that the VHA could just take over. It was actually written for the VHA to take over, to include like contact numbers for the actual providers who developed the treatment plan for me. I mean, I don't think that I could have had a better result for my physical care when I left the Marine Corps. They developed a really important. I was having my spine significantly degenerated, and it was kind of like a pretty rapid thing. And they developed a CARA and everything else. So when I left, showed up at the VHA, and honestly was really encouraged. And my first experience with the TRICARE doctors within the area I retired to was pretty poor. But I have this flagship VHA called VA Ann Arbor, University of Michigan, and turns out Michigan's a terrible place for medicine, and I've discovered why, and I understand why. Nobody else is really catching on, but it's the Michigan State medical records laws that makes it so terrible for patients and so abusive. If anybody wanted to actually look at fixing the problem, but anyways, back to kind of where my story was is my care was terrible. Right from the VHA, they essentially stopped all my stuff, right, and essentially trapped me right off the get go. I mean, they essentially like just really did a number on me. But I followed the process. I asked for a new physician, and they kind of restarted me, and I went through the entire process, and I ended up getting kind of close to what my treatment plan was. The DOD established for me eventually back at the VHA. So I was recovering. I was recovering from what the VHA, the stabilizing initial effects of the VHA. I was recovering from that, and then and one of the keys to that was throughout the process of kind of recovering from the initial damage the VHA did to me was that my pain clinic provider ended up taking over a mental health medication called Cymbalta that was being prescribed to me because the mental health clinic couldn't seem to consistently keep the prescription going and it would throw me into withdrawals. And it's a really terrible medical medication. And I'm pretty sure it's done some significant damage to me. And going along that lines was, he had taken over everything, I had a good relationship. Now, this is the type of pain doctor that represents, my decades of pain care experience. He really does represent one of the individuals that I've experienced. I didn't experience a bunch of pill pushers or whatever else. I've experienced even before the opioid epidemic in the DoD. I always experienced conservative individuals that when opioids were prescribed, it was on an as needed basis and really was to help assist moving and continuing on with functionality within life to keep you in life and engaged in life. As again, the best medicine and keeping one's purpose and not interrupting life. So much of that goes is completely forgotten and ignored now. There's this that therapeutic value of returning a patient to their life as comfortably and as rapidly as possible is medicine in itself. So, anyways, back to my story. I my doctor resigned. He resigned in protest. He felt that the VHA pain clinic was harming many patients, and that although he was reporting it, nobody was taking anything. Nobody's doing anything about it. And all the way to include that they even refused him a exit interview. So facts, right? Check it out. And so anyways, this is a doctor had me on, we developed a multi-year plan. Honestly, it was a 2-year plan and we talked about it every month. We spoke every month and went over things every month. And this guy was completely involved in my care and to get me to a place that with higher functionality and everything else. So anyways, he resigns and I can't, so my medication stopped showing up, which is multiple medications, but one of them did include opioids. And that was really the part that essentially, because that opioid was there, the VHA took that as license to essentially just say the most horrendous things about me and use it as a weapon against me and to use it to remove my voice and my civil rights through the authority that the Comprehensive Addiction Recovery Act gave them, along with several other mechanisms. But it's the part that everybody's missing, and there's elements to this that make it even worse. And again, most people don't recognize it. So that's what the pieces I'm going to cover and talk about is before I let this run. This in my mind, everybody who has to engage with medicine needs to watch this and understand where their actual rights are. Now, I speak in terms of veterans. I focus on veterans. These laws are not solely for Veterans Affairs. These are universal. If that doctor or that facility, that hospital, that system is getting federal funding, if they get federal reimbursement, these laws apply, and this is happening. The difference between this and the VHA is the VHA must keep records of the patients they're doing this to. And that's part of how I've been able to unravel what happened to me and be able to come here and kind of poke at a lot of people. Like I said, they mean well, but there's steps that they haven't quite gotten down to the basics, down to diagnosing where the fault and failure is or where the harm is occurring and what specific steps need to be taken to fix that. And like I said, I'll go back to that a little bit in a second. So with my case and what happened to me was my medicine stopped showing up. I contacted patient advocates and didn't have much, they weren't able to get a hold of clinics. They struggled trying to reach anybody. And I had an appointment at the VHA, and my VHA is Ann Arbor. And so I had an appointment for not the same clinic, different one. So I went in for that appointment. And while I was there, I went to patient advocates and said, hey, I'm having this problem with pain clinic. I can't get a hold of anything else. Can you assist me? And I said, sure, let's see what we can do. They got me a same day appointment that day. And so I went up and I saw my new provider. And let me tell you, the gem that was. But anyways, I met the new provider who was hostile and there was many other issues. And was very upset to see me that day, and that I had the audacity to come there and ask to get a same day appointment. I guess the hostility was unbelievable. Anyway, so after the appointment, I ended up reporting, and during the appointment, she had threatened some of my other treatments from other clinics. And again, it's I'm not a novice around government. I understand that she was overreaching like a great deal, so I reported it. Nothing came about it. And then the next month she came in, and again, and then let me rephrase. Let me back up a little bit. That same month, which was January 2020, I was able to get another clinic appointment there, and I saw another person who did a full workup on me. He's a resident from the University of Michigan, and it came to the conclusion I should be on the same treatment plan that my previous doctor had me on. She came in, she also concurred, and again, very briefly, she was in there. And again, I only saw the resident. There was not another provider present. She just came in at the end, and she didn't oversee him or anything else. She just came at the end, kind of reiterated it and everything else, and she demanded I do a urinalysis that day before leaving the hospital. And I was like, well, it's kind of improper, but all right, fine. And so I did anyways. And the next month comes and same issues. Patient advocates have not been able to, nothing, so secure messaging, I get nothing back on secure messaging. Patient advocates have had no luck themselves on getting contact reestablished or anything else. So third month comes in March. Again, my primary care can't get a hold of her, or in this clinic, this pain clinic, the patient advocates, nobody can get contact. And I'm having, again, these meds are not showing up. And by this time, I'm like 3 months without Cymbalta, and I'm suffering so terrible from the withdrawals from that stuff, the brain zaps and all that. And so I do a congressional. The congressional goes out requesting status of, what's going on with my care. And that's at one point, with the minutes of receiving the congressional, the record that 5 years later is finally before a federal judge. She wrote in there that I showed up to the clinic. I verbally and in a threatening manner, aggressively demanded opioids, as well as being non-compliant with all this stuff and having dirty labs. So that record, for bomb technician, that's a pretty much game over for us career-wise. You're not getting access to an explosive license. You're not getting access to Class 5 material, and you're not getting a new doctor. You're not going, if you allow your records to escape the VHA over a TRICARE or Medicare or anywhere else, you're not getting a primary care anymore. You're essentially completely done with your healthcare. You're not getting accepted. You've been deemed a violent threat to healthcare workers, and forget about it. Following the process, I asked for a clinical appeal. As again, it's law, and you're right as a patient. There's one exception to that, and that's if it's regarding if it's solely regarding opioid access. Mine was not solely regarding that; it was regarding a bunch of treatments. But instead of providing my clinical appeal, they put on a opioid risk review panel in which they invited a bunch of doctors who didn't treat me, along with other specialists, physical therapists, mental health, and everything else, who also weren't treating me, over the objections of those who were treating me. They sat on this panel, in which the pharmacist that sat on the panel as well, on a two-party recording, revealed the results of that opioid risk review panel, in which they did find that she treated me inappropriately, that she did not follow policy, that she did not follow law, but chose to validate her records on me and to continue the forged taper. I again asked for another clinical appeal, and eventually what happened was they sent me out to a community care. I didn't even ask to go to a different VHA like Detroit. Refused. In fact, I believe the doctor who I have for years asked for a new one, she is still assigned as my primary pain management doctor 5 years later. So I cannot escape. But anyways, so they eventually sent me out to community care, and again, this continues the problems, because if you don't understand, the back is not the back. The back is three body parts. Okay, the back is, and this is kind of how federal law works. And if you want, they say, so a lot of people, I'm all over the map on this. There's lots of conspiracy stuff here. Here's part of the conspiracy. You'll hear a lot of people in the harm reduction space talk about the 2016 CDC guidelines. All right, and it's quoted over and over and over again. All right, and the CDC will tell you that that's not healthcare law. All right, those guidelines and recommendations, everything else. But they're all idiots, and they're all not telling you that the Comprehensive Addiction and Recovery Act was law, and it does dictate how healthcare policy is for pain and opioid treatment. Okay, it does dictate the practice of medicine. It does dictate the standards of care within the Social Security Act. The CARA Act amends that, amends Medicare, amends Medicaid, as well as the reimbursement mechanisms. And this is where the conspiracy goes. All right, this dictates essentially the policy for the U.S. government as it pertains to opioid medications. All right, it is law. So they like to say it's just guidelines, but no, it was law, and it is law. And not only that, but it has been expanded now to be able to essentially be any. It's been so effective. Essentially, any treatment can now be added to this thing, to these censorship and these satisfaction surveys you hear about, and how effective these opioid-free management strategies are for pain. They are all biased and bigoted by the CARE Act. They're not science. They're balanced. The thumb has been on the scale since 2016 on all this stuff. But and that may be it may be viewed by a lot of people as necessary, but the effect of it has been to remove our rights, because it's the only way you could do that. Okay, you can't do this effectively unless you take away the civil rights of patients. All right, because otherwise the voice gets so loud that you can't ignore it anymore. But this is the one segment, and again, we go back to the stats, that the number one condition veterans have, number one above all else, is pain. Number one condition. But you will not hear anything in the conversation when we talk about the skyrocketing suicide rate that's still climbing. You won't hear about pain there. You won't hear about opioids. You won't hear about any of these things. Why? Again, it's because there is a healthcare law and a law dictating the standards of practice. And I say that loosely, but that is the effect. So back to, and again, whether you feel about opioids or not, that doesn't matter. This isn't a conversation about opioid medications. This is a conversation about patient rights, as well as essentially the black hole that was deliberately created for entire segments of the U.S. population to be hidden and buried under through the medical community. And if it's chronic pain patients, the last decade, the propaganda and the brainwashing has effectively blinded everybody to what happened to all those patients. And many of them are dead. Many of them are suicides, but those aren't tracked. Those are not tracked. Those are not tracked. Those are deliberately not tracked. So when these researchers are looking at these and are bringing up these cases, these are cases that have made it past the filters. Okay, this is the iceberg effect, that the Comprehensive Addiction Recovery Act was the cover to hide the bodies of the giant experiment they made to deprescribe opioids to the U.S. population. So on top of all this, and to speed this up to get to this video, which goes right hand in hand to what is occurring in the outputs, is so if you make a complaint as a patient 2 times and the VA thinks that they have resolved it or they've answered enough, they may now lie to Congress and oversight and say they've taken care of your concern. Okay, now go back. What the CARA Act did specifically before it was amended to take into account many other things, or allow its use for many other treatment modalities, but initially was for opioid access. Okay, specifically opioid medication access. So if a patient was showing up saying, "I want this opioid" or "I want opioids," you could censor that patient. All right, you could do a lot of things. You censor that patient, and that's not only that complaint specifically, but also the metrics coming out of there, and you essentially black hole them right at the point of care. And so for somebody who's in uncontrolled addiction, it may seem like it makes sense, and it's and it may even appear to be appropriate medical care. But by allowing that for the very first time in history, that veterans are a protected medical class above almost everybody else. And to get even more controversial, how about saying it this way: that the way the system is designed and the laws are written, veterans are a medical protected class almost above all others. And white males are protected even more than the general veteran is. Not because they're white males, as I think Tester just put out about the suicide thing, but because of how the priority scale breaks down within the Veterans Healthcare Administration, and that combat veterans who happen to be and injured, who happen to be majority white males, end up getting prioritized up. Okay. It's not the white male status. It happens to be the combat injured veteran status that happens to be like the highest priority in the Veterans Health Administration that drives that up. Okay, so but you can make it say whatever you want, and you can hide the data, because when you control all the voices and the complaints and the grievances, all these veterans at the point of care, you can make it say whatever you want. You can say the VHA is being a bunch of bigoted racist by focusing on white male veterans for suicide prevention efforts. But more accurately, what would be said is that they're prioritizing combat veterans, who would also include females and males of color, and not be controversial and try to create an issue and obscure the effects of your civil rights limiting laws that you pass and support it. We'll hit at those politicians like Manchin and him, who absolutely supported the CARE Act and drove the silencing of patients' voices. There's other effects to this, and so they're going to talk about prescription drug monitoring program and a few things to keep in mind. One of the other things that the CARE Act did, and where the resulting harm builds beyond the prescribing of medications and the availability of treatments, is this. Because of my complaints and that I continued to seek appropriate pain care, I was deemed a threat to the nation, and I was red flagged. Once you're red flag, it triggers that to then get put into not only these other instruments like the violence risk assessment instrument, but also the prescription drug monitoring program. And to really drive home the point of how dangerous and damaging these are, that a veteran who's been behaviorally red flagged, once that red flag has been removed from that veteran, for 41 months after the flag is deactivated, that data is still fed into the prescription drug monitoring program. And the same thing for veterans who are flagged for suicide. That is being fed into the prescription drug monitoring program. Now that doesn't just drive care decisions anymore. All right. And one of the things the CARE Act does, and where these and why I want people to watch this video and what they're saying is so important, is this. The prescription drug monitoring programs, accuracy, algorithms, quality assurance metrics are all protected and prohibited by law from being released to the public. We can't even see if the prescription drug monitoring program is accurate. You can't even see if it's red flagging or harming other people. There's no way to get in and see what is actually occurring under the hood and to see if the accuracy is even there. It's actually against the law for them to provide it. It's against the law for them to acknowledge that it's against the law for them to withhold those from FOIAs. And again, these prescription drug monitoring program operators aren't government necessarily. I mean, there's most of them are civilians, but they're actually protected by the federal law from disclosing what's happening under the hood, while most people who are now looking at harm reduction understand that program is causing harm. So on top of that, beyond treatment, beyond medicine, and where again most people don't understand, and I've discovered through my own efforts to correct my own record and to advocate for other veterans, is if you so request life insurance policy. Okay, if you're having issues, request a life insurance policy, and if it is denied, request the underwriting's rationale. And as I did, an underwriter's rationale will come out that there's a secondary, tertiary company that goes into prescription drug monitoring program with different programs that will analyze the prescription drug monitoring program to then output suspected diseases, conditions, and mental health issues that person might have. And then underwriting can recommend whether you get life insurance or not. It is directly, the entire rationale for denial, in my case for life insurance, was completely based on the prescription drug monitoring program that was 100% created from Veterans Affairs records that were wrong, and that the VHA has fought me for 5 years on getting corrected. The conditions that the underwriting and this, how they analyze the outputs, the diseases that they thought I had, the diseases that they stated I had, the conditions they thought I had, it was all inaccurate. It's all wrong. But it's all sole based on the Veterans Health Administration data that they got from the prescription drug monitoring program that now affects my access to even life insurance through a company that, like Bamboo Health, that runs these prescription drug monitoring programs, that I can't even now say, hey, they're wrong and they're harming me because the government has taken away my access to even look under the hood. So that's the parts that these people are missing and everything else. I'm going to let this play. These are all well-intended people, but the CARE Act is deliberately isolating us and keeping us from realizing what is the actual problem and where the harm is actually coming from. So here we go. And please share this out, and hopefully people can start understanding where the real harm is.
And we put a piece of legislation that changed. You cannot complain about the disbursement of drugs, because I can tell you a lot of the veterans knew exactly. They knew more than the pharmacists knew about what drugs they wanted and why they wanted them. And they would determine to get those drugs. And if they didn't, they would call their representatives, with senators or congresspeople, and complain they were getting poor service. And we found it was mostly over drug dispensing.
First, I'm going to tell you a little bit about what that flag system is that the VA has. We're going to talk a little bit about what issues could come up when you label a patient with BPD's chart as having disruptive behavior.
But I think they also were excited about it because they thought if we could cut down on prescribing, we would also cut down on overdose. And if you look at I have a chart in the book, but if you look at prescribing rates, they went like this, and overdose rates went like this. And this last tail is fentanyl. And so I don't think they anticipated the iron law of prohibition, where you clamp down on something that's safer and you end up with something more dangerous. And that's the space that we're in.
About it. How do you operationalize it, conceptualize it?
If I had another slide opportunity, there's a great graphic that really depicts this issue, this need. I want the base rate of reporting to go up. That's how I know I'm successful. And that seems counterintuitive, because I'm asking for money, I'm asking for resources. I'm going to say I'm giving you the optics and the data to show you that what we're doing is effective. People want to see the base rate of violence go down. And what will happen instead is that our success, if we're doing it right, is going to skyrocket the number of reports that we get. And within that, success looks like a change in the ratio of what you're being told about. So you want to get more. If you think about 1 in 5 events are usually reported, 1 in 5. I can tell you all about the research of how we get that, but they're about 1 in 5, and it's a universal phenomenon across sectors. If you know 20% of what is happening, and then tomorrow, next year, you double that, and people say, what just happened? You doubled the amount of violence with your program? Now we know 40% of what's actually happening. And we're going to triple it, and then we'll still only know 60% of what's happening. You want that 5-fold increase to finally think that you're being told about everything that's going on. And then within that, you want a big ratio of all the verbal, the ideation, the grievance level stuff. And then some where you actually caught it at research and planning and preparation. And then some of those are still going to be your breaches and your attacks. But if you can get the ratio of those to go down, within the rest of your data skyrocketing, it means that you're being effective. So there's some really nice things to think about wanting more reports as opposed to wanting them to go away.
So for those that aren't familiar, the Veterans Health Administration, the VA, is the largest integrated public health system in the US, and it utilizes a really extensive connected electronic medical record database. There's over 6 million veterans enrolled in the healthcare system across almost 1,300 facilities. And as part of the efforts to improve identification of patients who may be at a higher risk of either hurting themselves or hurting others, the VHA developed a patient record flag system. So there's different flags that can be issued and assigned to a patient's chart. One flag indicates the patient is at acute high risk for suicide. Another flag indicates that the patient is at acute high risk for disruptive behavior. When those flags are then assigned to someone's chart, they're viewable by all VA providers and staff when they then open that patient's electronic medical record. So the flag system is meant to be a systems level safety program focused on prevention instead of punishment. And it was designed to help improve provider safety when you're providing care for patients at higher risk of violence. The flag system hasn't had a lot of research, but it has been found to be heavily used, often with guidance to provide police protection for providers. And providers in general have indicated satisfaction with the system. So between the two categories of flags, there are a lot of differences. With a suicide risk flag, they are administered by a suicide prevention coordinator, and they're evaluated every 90 days. They're reviewed every 90 days to see if the chart should be added, the flag should be added or removed. Disruptive behavior flags are administered by the Disruptive Behavior Board and the person who coordinates that, and they aren't reviewed. They're only reviewed every 2 years, and at that point, at the 2 years, they'd evaluate to see if the flag could be removed or not. One of the things we'll talk about that we think could be one of the biggest issues or discrepancies between them is when you get a suicide risk flag, it really indicates greater access to care. The suicide prevention coordinators are trained in multiple interventions to help with suicide prevention. They're going to, check in multiple times. There's going to be multiple evaluations, sometimes weekly, especially after release from inpatient mental health. And there's just a lot of access to care that comes with those flags. Whereas the disruptive behavior flag can indicate a decrease in access to care. When you receive one, it can limit where you're able to receive care. You might not be able to go to a CBOC anymore, which is a community clinic. You might have to go to a main hospital. You might have to check in with police first. You might not be able to work with certain providers. So it can be a decrease in care. And the disruptive behavior coordinators do not have training in providing intervention for this group. So there's no sort of coaching on how to reduce these problematic behaviors. There's not discussion around working on anger or managing behavior. It's just sort of risk assessment, and then the flags put on the chart. So there has not been a lot of research in this area. However, when there has been a few studies that did chart reviews for patients who have received disruptive behavior flags, personality disorders has been in the top 2 or 3 of the diagnoses, most common diagnoses for multiple chart reviews.
So what are those possible impacts? Obviously, there's stigma associated with the diagnosis, and as Sharon pointed out, also stigma associated with getting that flag. So it's kind of this compounding effect. It also compromises privacy. It can restrict their care, as Sharon went over. And patients don't know how to address it when it does happen, or like how do you approach getting removed from your chart, things like that. So it's on there for at least 2 years. And the other side is really just some actual real life examples of reasons people have been given behavioral flags. So everything from raising your voice to like physical violence. So just to give you guys some examples. Next, thanks, Sharon. So with that, I do want to turn it over to my colleague Chelsea, who's going to look at this from the not so much the research perspective, but more of like what are vets and veterans saying.
Thank you. Hi, everyone. So as Dr. John had said, we wanted to think also about what are people with lived experiences of these disruptive behavior flags, thinking about this issue. And unfortunately, there really isn't any qualitative or quantitative literature out there to help guide us. So we turn to what opinions are being posted and talked about publicly. So what we're going to share next are just some different views that have been posted publicly on social media by folks who've experienced or have concerns about disruptive behavior flag systems. So I won't read through all of these, but you see one that says, I'm being affected by the VA disruptive behavior you reported in the past, help. One that says, I think the VA disruptive behavior system has major flaws and needs to be overhauled, no accountability, no transparency, and lots of loopholes for staff to use it to retaliate. So a lot of concerns about confusion and secrecy with this. Thank you. Over here, you see one that says, under VA policy on patient record flags, federal bureaucrats classify that as threats based on difficult, annoying, and non-compliant behavior. You see a clear mistrust of the VA, a clear apprehension to the system, and concern about things like complaints, things like trying to advocate for themselves being misconstrued as disruptive behavior and creating problems because of that. Right about now, the Disruptive Behavior Committee is meeting to decide how to handle me. VA employees are filing disruptive behavior reports against vets who threaten suicide, file complaints, or complain about claims that are backlogged. Where can I find regulations on this disruptive behavior committee? Shouldn't every hospital follow the same procedure? So you just see a lot of concern from veterans in the VA healthcare system that there's no regulations, it's not transparent, as well as that they don't feel their confidentiality is being maintained, that things are getting given to law enforcement, and that they can't advocate for themselves about issues within the healthcare system, or even potentially disclosing suicidal ideation. So just to summarize, while there are certainly benefits and providers like a lot about the flag system, and it is one of the ways to help providers have protection when working with potentially violent populations. On the other hand, those with lived experiences are really reporting finding them not helpful, and at the very least that they're confusing and clearly quite stigmatizing.
There's a problem there to begin with. And we are not in a space where we should be allowing people to have the expectation that subtle forms of violence are acceptable. So they're not. Violence, specifically in healthcare. And I'm delighted to have a really wonderful guest this morning, and I want to tell you a little bit about her as we get started. Lynn is just an unbelievable person and expert in this field. She's currently the president of Lynn Van Mount LLC, a private consulting firm. And she was also a senior director of threat management for a large multi-state not-for-profit healthcare organization and the past national director of the United States Veterans Health Administration's Workplace Violence Prevention Program. And predating her executive leadership roles, Dr. Van Mal's clinical practice focused on post-traumatic stress disorder recovery. Her work in violence prevention and behavioral threat assessment and management has been presented nationally and internationally. She served on the Joint Commission's Technical Advisory Panel for Workplace Violence, and her work in violence prevention solutions for healthcare settings was published in the 2016 Journal of the American Medical Association. And I could go on, but I'm going to pause there. So, Lynn, thank you so much for joining us today. I'm so grateful that you're here with us.
Thank you so much for the invitation. It's my honor.
Sure.
To your question soon. But Liz, in your book and also in this talk, you started with this sort of fundamental premise that people in pain and people who use drugs or people with substance use disorders are pitted against each other. And as a result, sort of no one wins. And so can you talk about the harms of this sort of dichotomy and this sort of perceived conflict between people in pain and people who use drugs?
Absolutely. So I think one of the biggest problems is that we've zeroed in so heavily on the opioid as the problem. And so then we treat them as if they're a zero-sum game. So if we overprescribe opioids, then pain patients are taken care of. But then there's this glut of opioids that is available for people to get hooked on. But if we underprescribe opioids, we might solve this addiction problem, but pain patients don't have access to the treatment that they need. The problems that we're dealing with are much bigger than the opioid itself. And I think the problem is that these two groups get pitted against each other, and then they see each other as the problem instead of looking at the larger healthcare system and why it's not working for either one. Both substance use disorder and chronic pain are incompletely medicalized. And by that, I mean, doctors get very little education, if any, education and training on them. And it's kind of seen as perfectly legitimate to refuse to treat those kinds of conditions. So they don't sit within the heart of the healthcare system. And so I think these two marginalized groups would be in better shape if they saw themselves as having shared fates and understanding that they've both been harmed by this system, and then mobilizing collectively instead of saying, well, I hear this from pain patients. They're saying, well, I was responsible, but it's these addicts. I mean, I wouldn't use that word, but it's these addicts who are doing terrible things. And then you hear some of the same kind of thing on the opposite side. And I don't think they're on opposite.
30% off of fleecing patients at the Princeton University website. And we'll put this link in the chat. If you haven't bought it already, I really encourage you to. It's an excellent book. It's super readable. I think great for academics, great for researchers, great for students, great for advocates, and really anyone concerned about the overdose crisis and anyone who wants to think critically about what we can do to save lives. So now I'll introduce our speaker for today. Dr. Liz Chiarello is an associate professor of sociology at St. Louis University who conducts research at the intersection of healthcare and law. You can read her full bio at the link in the chat. In an overview of today's discussion, Dr. Chiarello will give an overview of the book, followed by a moderated discussion with me, and then an audience Q&A. So please feel free to drop your questions in the chat or Q&A box throughout the webinar. And with that, I'll hand it over to Dr. Liz Chiarello.
Thank you so much, Eliza, for that kind introduction. I'm really delighted to be here. Can you just confirm for me that the screen is working well? Like, do I need to do something to move this gallery?
You look perfect, and we can't see any of your notes.
Perfect. And can you see everybody else that you need to see?
Yes, thank
Perfect. You. Okay, good. Just double checking. All right. Well, thank you all for being here. I'm really delighted to be here. The Drug Policy Alliance does such great work, and so I'm really honored to be invited. I also want to make sure to thank the Harvard Radcliffe Institute, the National Science Foundation Career Award Program, and St. Louis University for supporting this work over the years. So I'd like to begin by talking about the stories that we tell ourselves, the ones about the problems in our society, what causes them, and who they hurt. There is a story that you most definitely know. It's the story about how an evil drug company flooded our communities with dangerous opioids and got our friends and families hooked. But the author, Chimamanda Ngozi Adichie, warns us that there's danger in a single story. She says that it's not so much that a single story is wrong, as that it's incomplete. The United States has spent the last 2 decades trapped in the worst overdose crisis that this country has ever seen. And even though we've spent billions of dollars to solve the problem, things keep getting worse. Maybe we keep failing because we've gotten the story wrong. So I'm going to tell you a different story, one you probably haven't heard. It's the story about how efforts to stop the opioid crisis have changed the very heart of healthcare, how people who go into healing professions to treat patients have been forced to police them instead. So let's start by putting the story that we know in perspective. What's often called the opioid crisis or the opioid epidemic is really the confluence of 2 crises, an overdose crisis and a pain crisis. And people in pain and people with substance use disorders have been pitted against each other in a national fight over opioids. Blame for this crisis has largely been placed on 2 groups, the pharmaceutical industry and doctors. Purdue Pharma, the maker of OxyContin, has been accused of peddling an addictive substance and refusing to stop when their drug proved deadly. And doctors have been called drug dealers in white coats and accused of handing out opioids as if they were candy. Hundreds of physicians have been arrested and prosecuted for overprescribing opioids. For example, this is Lisa Singh. She was an osteopath in Los Angeles, and when 14 of her patients died, she was convicted and sentenced to 30 years to life in prison. Dr. Seng's case is notable because she was the first California physician ever convicted of murder for overprescribing opioids. She was also one of the first in the United States. And her case was also a turning point for law enforcement because it created a playbook for future prosecutions. Seng's case is an extreme example, but what's more common is that law, regulation, and guidelines have all aimed to cut down prescribing rates. So the reason goes like this. If the cause of the opioid crisis is overprescribing, then if we reduce the number of prescriptions, we can save people from overdose. And we continue to buy into that notion even when the majority of overdoses today are due to fentanyl and other illegal drugs. One way that lawmakers have tried to reduce overdose deaths is by implementing prescription drug monitoring programs, or PDMPs. PDMPs are surveillance technologies. They were designed for law enforcement, and they're being used in healthcare. And they track all of the controlled substances, not just opioids, in the state. And so PDMPs feed aggregated pharmacy data to healthcare providers who can use it to track patients, but they feed that same information to law enforcement who can use it to track providers and patients, which makes PDMPs two-tiered surveillance technologies designed for law enforcement, used in healthcare. I theorize that PDMPs are Trojan horse technologies. So if you think back to the Trojan horse story, one thing that's important to remember is that the Trojans were horse people. Like, this was kind of their thing. And so when they saw this enormous wooden horse, they thought to themselves, well, of course, what better symbol to commemorate our victory than this horse? But when they wheeled it behind their walls, they never suspected that hiding inside were Greeks who wanted to kill them. The PDMP works the same way without, felling a civilization. Healthcare providers already use a host of technologies, so adding one more seems pretty reasonable. But what they don't realize is that PDMPs are embedded with enforcement logics that emerge through daily practice. PDMP use reorients healthcare providers towards surveillance and enforcement. Now, the other reason that PDMPs are so appealing is because the enforcement environment surrounding healthcare practice has grown more treacherous. The main law that governs opioids is the Federal Controlled Substances Act, which was passed in 1970, and it requires physicians to prescribe in good faith, which means for a legitimate medical reason and with a patient with whom they have an established relationship. And then that same law assigns pharmacists what's called a corresponding responsibility to make sure that that medication is being used for a legitimate reason. In the past, it was really hard for law enforcement to assess prescribing and dispensing practices. That is not true anymore. In 2006, the Drug Enforcement Administration created tactical diversion squads that focus specifically on healthcare crimes. And then the PDMP gives enforcement agents fine-grained information about opioid provision. The other big change is that in 2016, the Centers for Disease Control and Prevention adopted a set of guidelines for treating pain. And these guidelines were almost immediately treated as if they were law by healthcare leaders, insurance companies, and lawmakers. So this is the technological, cultural, and legal environment in which healthcare providers practice today. They have been blamed for the worst drug crisis in US history. They have a law enforcement surveillance tool at their disposal. Law enforcement has gotten better at watching their every move, and the CDC has issued guidelines that have been interpreted as law. So I was really interested in how this broader context shaped decision-making about opioid provision. So I interviewed 337 physicians, pharmacists, and enforcement agents from 2009 to 2019. Participants included three types of physicians. I talked to primary care providers, pain specialists, and emergency medicine doctors. I talked to community pharmacists who are working in chain and independent drugstores, and a wide array of enforcement agents. Too many to list here, but what I will tell you is that some of them worked on the criminal side of law, and others worked on the administrative side of law, so things like boards, for example, like the medical board, the pharmacy board. And I designed the project by selecting 3 states based on the location of the PDMP. So California, where it's in the Department of Justice, Florida, where it's in the Board of Health, and then Missouri was my negative case. They didn't have a PDMP, and then we just got one a couple of years ago, and lucky for my research design, they got one in the Board of Public Health, and so I still have this 3 different state design. But I did it this way because I figured that where the PDMP was located might affect how it was used. Like maybe it would get used like an enforcement tool in California, and get used more like a healthcare tool in Florida. I didn't really see these differences, but I wanted to make sure I could capture them if they were there. And then I supplemented this work with interviews in 5 other states, some of which I did as pilot interviews, and then others I did for other reasons that we can talk about in the Q&A. But these are really the big 3 states that I focused on. All right, so we're talking about this treacherous enforcement environment, and let's think for a minute about what could happen to doctors if they overprescribe opioids. They could lose their ability to prescribe controlled substances if the DEA yanks their registration. They can lose their ability to bill Medicare and Medicaid if fraud agencies restrict their national provider identification. They can lose their capacity to practice medicine if the state board revokes their license, and or they can lose their freedom if they're criminally sentenced for dealing drugs. Pharmacists face similar consequences. PDMPs are a boon to law enforcement because it makes their tasks easier and more efficient. Before the PDMP, law enforcement had to, if they were investigating a doctor, they had to drive around from pharmacy to pharmacy around that doctor's practice to see if they could gather enough of their prescriptions to try to see some sort of pattern. But the PDMP changed that because now, with a click of a button, they can see what physicians are prescribing. So this legwork that they used to do has become desk work. Federal prosecutors use the PDMP alongside other databases, like, for example, ARCOS, which is the Automation of Reports and Consolidated Orders system that tracks controlled substances all the way from manufacturing to distribution. For example, Tyler, a federal prosecutor in California, compared PDMP data to ARCOS data and learned that, these are his words, a small mom and pop pharmacy was the #1 purchaser of oxycodone in the entire county of Los Angeles, more than UCLA Medical Center, more than Cedars-Sinai. Showing the discrepancies between those two databases helped Tyler convince a judge and jury that the pharmacy owner was intentionally engaged in illegal activity. Enforcement agents tell me that they go after the worst of the worst. And if you look at how big the DEA is, there's some reason to believe them. I mean, the DEA is not that large as an organization. They are large. They loom large in our cultural imagination. But in terms of the actual territory that they're covering, they don't have the capacity to go after every doctor that they want to go after. And they certainly couldn't go after every doctor who is mildly overprescribing opioids. But that doesn't necessarily matter for healthcare providers, because all they know is that some of their colleagues are being arrested and prosecuted for things that they themselves do, prescribing opioids. So this can create a chilling effect that is evident in how doctors and pharmacists treat patients today. One of the biggest challenges that physicians face is deciding which patients are deserving or undeserving of care. And I should pause a minute and be very clear. This is sociological language. You know, when we talk about the social construction of deservingness, that means something sociological. Physicians did not tell me, oh, I'm thinking about who deserves care or not. But it was very clear in their responses to my questions that there's a moral valence in how they're making the decisions that they do. And so there are 3 types of patients who might come looking for opioids. There are pain patients, patients with substance use disorders, and then people who are diverting or selling their medications. And of course, the same patient can belong to more than one group. Now, legally, pain patients are the only patients to whom doctors can legally dispense opioids for pain. But they have a hard time figuring out who those patients are. And that's why they find the PDMP so helpful. Physicians use the PDMP in conjunction with other policing tools. So most of the physicians I talk to require patients to sign a pain contract, which is basically a legalistic document that sets restrictions around their care. And it's very clear that any violation of this contract can result in termination from the practice. The pain contract sets the rules of engagement. And then other enforcement tools, so things like the PDMP report, urine drug screens, and random pill counts, track patient adherence. When faced with a patient deemed undeserving, physicians can either prescribe opioids and risk legal action, or they can dismiss the patient and fail to help someone in need. They cope with this impossible situation by passing patients along to other providers who they think can provide better care. There's this sort of mythic elsewhere, right? Like, I'm not willing to treat this patient because I'm too concerned about my license, but surely someone else is going to take this patient on. So what happens is patients get treated like a hot potato. The core tension between general practitioners and pain specialists arises from this question of who is going to prescribe opioids in the long run. They're both willing to do it for a short period of time, but they don't want to be the one who's primarily responsible for opioid provision. So general practitioners want pain specialists to do it, but pain specialists prefer to spend their time doing procedures that are fast and lucrative instead of prescribing opioids, which is slow and unprofitable. When Seema inherits patients who are already on opioids at her practice in the San Francisco Bay Area, she tells the patient, okay, I'll prescribe for 3 months, but then they have to go to pain management. And her expectation is that the pain specialist is going to taper the patient down. Now, pain specialists balk at this kind of scenario. In their eyes, general practitioners are dumping undesirable patients on them. Scott, who works in private practice in Kansas City, feels backed into a corner. He says, the primary care says I don't write for opiates, the pain specialist does, and then they come to me with that expectation, and I want them like I want a freaking hole in the head. Pain specialists have their own strategies for avoiding dumps from primary care. Some, like Scott, simply refuse to treat the patient. I don't want to, he says. I tell them I see all kinds of red flags. You're on benzodiazepines. Your urine's dirty from marijuana. You're not showing up to work. Patients respond, well, what am I supposed to do, doc? I have 1 pill left and my primary care doc won't write for me. Scott tells them, I don't know, and walks out, leaving the patient, in his words, irate. When primary care providers and pain specialists refuse to see patients, the patient often ends up in the emergency department. Now, emergency medicine physicians don't think of chronic pain as an emergency, and they're frustrated with these other doctors who refuse to treat. Says Matt, an emergency medicine physician, I think patient abandonment is a big issue because then it pushes them back in my lap. Patients are trapped in an endless loop, from general practice to pain medicine to emergency medicine and back again. They have a really hard time finding a medical home. Physicians have learned a lot about opioids in the last decade, and they are genuinely concerned about doing more harm than good. However, the tools available to them push them towards enforcement. Like the mythic Trojan horse that distracted the horse-loving Trojans with its shape, enforcement tools have the same contours as healthcare tools. However, they also have a pernicious quality that becomes evident when we see patients policed out of treatment and shuffled between practitioners. Forced to straddle the line between treatment and enforcement, physicians police patients and call it care. Patients who are lucky enough to get a prescription have to run another obstacle course, this one at the pharmacy. Pharmacists are caught in a dilemma. Their employers urge them to be quick, and law enforcement urges them to be cautious. But it was really hard to do both of those things until the PDMP came along. The PDMP made pharmacy work easier. It did not necessarily make it better. The PDMP operates as a Trojan horse technology that ushers enforcement logics into healthcare work and detracts pharmacists' attention away from patient care through three mechanisms: changes in pharmacist routines, changes in their relationships, and changes in their roles. Prior to the PDMP, pharmacists relied on red flags like appearance and behavior to determine whether or not patients deserved opioids. A lot of times they relied on a gut feeling. They would say to me, oh, you can tell as soon as somebody walks in the door. And then when they refused to dispense, they told the patient that the drug was out of stock. And the function of that was that they avoided confrontation with a patient. Now, pharmacists are far more assertive now that they're armed with a PDMP. Laura, a California chain pharmacist who I interviewed in 2013, explains how she uses the PDMP to confront the patient. Before, I was more like, I'm not comfortable. And then the patient's like, well, why aren't you comfortable? And now we're like, well, you know, within 30 days, you filled 480 tablets. That's a little too much. And so now they're like, okay. PDMPs also help pharmacists to reimagine and reconstitute relationships with physicians and with law enforcement. Organizational policies requiring PDMP use help pharmacists to circumvent traditional power dynamics when calling physicians. Tracy describes how this has changed her interactions. She said, when I chain implemented a checklist, physicians were not happy. They were like, what is this? I've never seen this. Why are you asking me so many questions? And basically, we're just like, well, we need to make sure the patients are not legitimate. We don't use that word, but that they're under the correct care. We just need everything to be documented now. So now they're kind of used to it, but yeah, they were pretty hostile. PDMP use also helps to create closer alliances between healthcare providers and enforcement agents. And I heard this from both sides. I largely heard it from pharmacists, and then I heard it from law enforcement who said, you know, pharmacists are some of our best resources when we're trying to go after a doctor or a patient. Prior to the PDMP, pharmacists didn't consider drug monitoring part of their job. It was. I mean, the Controlled Substances Act has been in effect for 50 years now, but they had a very different idea about what they were supposed to be doing. So one pharmacist, Sarah, stipulated that she was not in the police business. And they said this to me all the time. I'm a healthcare provider. I'm not a cop. With the advent of PDMPs, however, pharmacists conceive of their relationship with law enforcement much more positively. Min, a Kansas City pharmacist, collaborates with law enforcement. And he told me that he once helped catch someone who had written a fraudulent prescription. He said, we call the police. They said, okay, tell us exactly when she's going to fill it and when she's going to pick it up. He put candy instead of opioids in the pill bottle. And he said, when she came up to the window, the cops were right there. PDMP use, along with a number of other social factors and legal factors, has also shifted the very core of pharmacy. Pharmacists are at once asked to be medical and legal gatekeepers, oriented around medical science, oriented towards law and law enforcement. They once found these roles incompatible. Thanks to the PDMP, the stressful experience of being pulled in two directions at once soon gave way to a new, largely subconscious, reframe and embrace strategy that allowed them to harmonize competing roles. In the end, pharmacists reframed legal gatekeeping as medical gatekeeping to justify their involvement. Charlotte told me that the monitoring program helps her fulfill her ethical obligations. I mean, a pharmacist took an oath to do no harm, just like other medical professionals, so it helps us prevent causing harm. By now, you've seen that the way pain patients and patients with opioid use disorders are treated in the healthcare system looks very different from what we expect. Policed at the clinic, the hospital, and the pharmacy counter, what happens to patients who don't make the cut? Where do they go when no one will prescribe or dispense their medications? The short answer is they suffer. The amount of opioids prescribed has become a litmus test for patient care. The lower, the better. Many healthcare providers protect their own metrics by routing patients out of the healthcare system. Physicians and pharmacists engage in two forms of routing, indirect and direct. Indirect routing includes firing existing patients, tapering patients' doses, and rejecting potential patients. Physicians often invoke law to justify firing patients. Nicole, an internist, describes what she tells patients who have broken the rules. She relies heavily on the pain contract to justify her choice to discontinue care. I'm just like, I'm not going to be able to prescribe this medication anymore. And when the patient asks why, she says, well, your drug screen was positive, if that's what happened. And they push back and they say, well, it's a false result, which can happen with your own drug screens. And I'll be like, well, that may be true, but unfortunately, this is what's stated in your pain contract. In contrast to indirect routing, which sends patients on a road to nowhere, sometimes physicians and pharmacists send patients straight into the arms of law enforcement. This is direct routing. So think back to Min, who put the candy in the pill bottle instead of the opioids. He says that police kind of use me as a PDMP resource. And by that, he means that local police who don't have access to the PDMP ask him to share the information and he complies. So just think for a minute about law enforcement calling up and asking your pharmacist about any other kind of healthcare. And you can get a sense of just how different this is from how healthcare normally operates. Research on spurned patients reveals an unsettling truth. Lack of access to healthcare drives people with substance use disorders into illegal drug markets where labels have no meaning, fentanyl masquerades as prescription opioids, and the strength of a dose is anyone's guess. Meanwhile, for pain patients, sudden loss of opioids brings pain roaring back, leaving these pain refugees desperate. With nowhere to turn, some patients take their own lives. This is Doug Hale. He was first prescribed opioids in 2001 after he started to experience bladder inflammation from a surgery. And he tried all kinds of interventions, but opioids were the only thing that worked. His pain was well managed until his primary care physician decided to taper him and gave him 1 month to get completely off of opioids, which for anybody on a high dose, this is an extremely fast taper. He tried detox, which didn't work. And when he returned to his doctor asking for opioids, his doctor told him, I'm not going to risk my license for you. The next day, he shot himself in his backyard. In the note he left for his wife, he said, "I can't take the chronic pain anymore." He was 53 years old. Stories like Doug's bring into sharp focus the real human cost of anti-opioid policy. In 2009, I attended a law enforcement conference in Tampa, and that's where I heard Kevin, a narcotics officer, tell his story. His daughter, Brooke, had started using drugs as a teenager. He got her into inpatient treatment, and then the facility expelled her for a rules violation. You know the rule that she broke? She had some ibuprofen. He was livid. He said, have you ever heard of a diabetic kicked out because they had an ice cream cone? For a long time, the police force had been extending Brooke professional courtesy because of who her dad was. And eventually he said, stop doing that, just let her experience the consequences of her actions. So eventually she was sentenced to 4 months in jail. During that time, he said she was off drugs, and he caught glimpses of the girl he once knew. But that reprieve was short-lived. Brooke was using heroin with friends one night when she started to overdose. Her friends, scared that her cop dad would arrest them, made her leave the house. Weak, she drove to a church parking lot where she stopped breathing. She was only 19. Brooke is one of 100,000 children, friends, siblings, and parents who die each year from drug overdose. Their deaths are signs of a broken healthcare system that casts patients aside instead of providing them with the treatment that they need. Moreover, they are signs of a frayed social safety net that fails to support people who suffer. There isn't enough high-quality treatment to go around. People who seek care inhabit a twisted realm where evidence-based care is sparse and expensive, and readily available treatment can do worse than fail. The world needs better treatment and more of it. But treatment is not enough. We have to find ways to mitigate suffering ahead of time. That is why we need a three-pronged solution that integrates treatment, harm reduction, and prevention. A comprehensive approach will ensure that providers have the right tools for the job and help repair our social fabric to stop people from falling through the gaps. Nothing less will do. First, we need to expand treatment capacity by urging physicians and pharmacists to provide buprenorphine, one of the gold standard treatments for opioid use disorder. When it comes to pain, physicians should right-size treatment. One-size-fits-all regimens don't work. Physicians should reclaim their professional power and autonomy and reject reactionary policy that turns them against their patients. Together, physicians and pharmacists can advocate for policies that would help them make treatment more available. 3 steps would go a long way towards achieving this goal. They can expand telemedicine. They can move methadone treatment into pharmacies, and they can allow pharmacists to provide both methadone and buprenorphine in tandem with physicians. We also need to invest heavily in harm reduction. We have harm reductionists to thank for syringe provision programs, the widespread availability of naloxone, overdose prevention centers, fentanyl test strips, and much more. These approaches have gone a long way toward reducing overdose and drug use-related harms. It wouldn't take much to extend harm reduction philosophy to chronic pain sufferers. Doctors should encourage any positive change instead of rejecting patients or forcing them onto strict tapering schedules that put their health and their lives at risk. In the grand scheme, the overdose crisis is a symptom of much larger social problems that cry out for attention and investment. Healthcare and criminal justice are vast fields, but they offer blunt tools for addressing social problems that give rise to drug crises. We can't arrest our way out of homelessness, joblessness, or domestic violence, nor can prisons repair mental health. We need to invest in social workers, psychologists, housing specialists, and employment experts who have more refined tools for the job. And we need to devote funds to agencies that provide these kinds of services. The bottom line is, investing in healthy communities is an upstream way to prevent drug crises, and it offers the added benefit of tackling other social problems at the same time. We should also pay close attention to what doesn't work. My research offers a clear warning against the mindless embrace of technology. Tech promises to do a lot of things, but we need a measured approach to implementation, one that precludes unintended consequences that result in harm. Can we solve social problems without sacrificing the essence of social fields? Through perseverance and best practices, empathy and education, common sense and common ground, we most certainly can. Thank you.
Thanks so much, Liz, for that wonderful presentation. I'm really excited to dig in with some more questions and some audience Q&A. We have a few questions from the audience rolling in, and I'll invite people to continue to write in the chat or in the Q&A box, and we'll get to your questions soon. But Liz, in your book and also in this talk, you started with this sort of fundamental premise that people in pain and people who use drugs or people with substance use disorders are pitted against each other. And as a result, sort of no one wins. And so can you talk about the harms of this sort of dichotomy and this sort of perceived conflict between people in pain and people who use drugs?
Absolutely. So I think one of the biggest problems is that we've zeroed in so heavily on the opioid as the problem. And so then we treat them as if they're a zero-sum game. So if we overprescribe opioids, then pain patients are taken care of. But then there's this glut of opioids that is available for people to get hooked on. But if we underprescribe opioids, we might solve this addiction problem, but pain patients don't have access to the treatment that they need. The problems that we're dealing with are much bigger than the opioid itself. And I think the problem is that these two groups get pitted against each other, and then they see each other as the problem instead of looking at the larger healthcare system and why it's not working for either one. Both both substance use disorder and chronic pain are incompletely medicalized. And by that, I mean, doctors get very little education, if any, education and training on them. And it's kind of seen as perfectly legitimate to refuse to treat those kinds of conditions. So they don't sit within the heart of the healthcare system. And so I think these two marginalized groups would be in better shape if they saw themselves as having shared fates and understanding that they've both been harmed by this system, and then mobilizing collectively instead of saying, well, I hear this from pain patients. They're saying, well, I was responsible, but it's these addicts. I mean, I wouldn't use that word, but it's these addicts who are doing terrible things. And then you hear some of the same kind of thing on the opposite side. And I don't think they're on opposite sides. And so I think mobilizing in favor of common sense drug policy, as well as broader social supports and prevention that would benefit both groups, would be far more effective than allowing themselves to be in this tug of war over one type of drug.
Yeah, thank you. And of course, as you point out in the book and as you did in your talk today, like these groups aren't necessarily distinct, right? There's certainly overlap between people with substance use disorders or people who use drugs and pain patients.
And the book starts, the first line of the book is the problem is pain. And I believe that the problem is pain, whether we're talking about mental and emotional pain or we're talking about physical pain, it doesn't matter. That's the problem we're dealing with. And opioids neither fully fix that pain nor cause that pain. We have to have a broader perspective to come up with reasonable solutions.
Totally. And I'm sorry, I'm already going off script of our predetermined Q&A. But okay. I knew this, but I was so struck in the book by, you had a few stats on the lack of pain education in medical schools and the lack of education on addiction and drug use in med schools. Do you remember those stats? Or can you? Okay, yeah.
Numbers mean nothing to me, so no.
It's something like, only like 5 or 10% of like any school provides any sort of education around pain or addiction medicine. It's really astonishing for a country that's in a horrible overdose crisis.
It's astonishing. And then who does the education is law enforcement. So I sat in on a pharmacy class in New Jersey, and it was a DEA agent who came in and educated those pharmacists. And this is where I think we really have to think about the ways that the lines between healthcare and law enforcement get blurred. Healthcare providers have to figure out what their position is on opioids, on pain, on substance use, because otherwise they're going to be influenced by someone who isn't necessarily as invested in healthcare as they are.
Yeah, totally.
And so different states had adopted all of these different laws about whether or not they could opt out. And so I designed this study. It was so beautiful. 4 different states with different laws, a more conservative and a more liberal county, different kinds of organizations. It was this maximum variation sample. And then I sat down with pharmacists and I asked them, what would you say are the key ethical issues that you face in daily practice? And across the board, they said opioids. And this was 2009, before opioids were fully on the national agenda. And so I got all this data about how they were making decisions about opioids. And then that really formed the basis of this whole project.
So interesting. Thank you. Thanks. I love Jennifer Carroll in the comments saying the repro justice to drug policy pipeline is well trafficked.
Fact.
So you talk about how physicians are operating in a legal gray area in many ways and deciding when and how much to dispense. So how does that ambiguity impact patient care as physicians work to protect themselves in their role as physicians?
I have a lot of sympathy for physicians. I know not everybody does, but I do have a lot of sympathy for the way that their enforcement environment has changed. And as a sociologist, I know that there's a disconnect between the enforcement environment as they imagine it and the enforcement environment as it operates in practice, which is why it was so important to me to talk to law enforcement and get a better sense of what they're actually doing. Because I think physicians have this idea in their head that, you do one thing wrong and the DEA is going to come after you or the board is going to come after you. And that just is highly unlikely. But I also understand being risk averse. And physicians are inherently conservative. And I don't mean that politically. I mean that in terms of their practice. They're judged by their peers in board of medicine cases, in malpractice cases. So they want to know that they are practicing well within the standards of care. But there is tension, I think, between protecting one's license and protecting one's patients. When they get their white coats at this white coat ceremony, they raise their hands and they take an oath. And that oath says, I solemnly pledge to dedicate my life to the service of humanity. The health and well-being of my patient will be my first consideration. So I think about Doug Hale's doctor who said to him explicitly, I am not going to risk my license for you. And I think he failed to put his patient first and had catastrophic results. And I think that same thing happens when physicians taper their patients back and thrust a well-managed patient into horrific pain. And I'm starting to talk to those patients, and I have to say their stories are awful. And I think what happens too is we've decided that these patients are not to be trusted. There are all these narratives about they lie and they're manipulative, and all they want is a drug. But I think that if we take seriously what patients say about their pain, we can see the tremendous harm that's done when doctors feel so vulnerable to law enforcement.
Yeah, thank you. And I'll just, in case you didn't see it, I'll uplift this comment in the chat where someone said, I sent the link to this talk to my PCP, my primary care provider, and my psychiatrist. I've been treated so horribly by pharmacists for trying to access medications, and it has made me so uncomfortable. I appreciate the book as a tool to use in my tool belt. This is amazing. So it's really, what you're saying is true. So many people have been impacted by these everyday decisions that, healthcare providers are certainly taking seriously, but also probably, as you said, sort of view as a routine everyday decision and are often making sort of quick snap judgments.
Yes, and so many patients are being treated like that. So the person who made that comment is in really good company. And I think the challenge, and part of why I feel like writing this book was so important, is because for patients, the experience is just of me being mistreated, and they don't necessarily know where it's coming from. People don't know about the prescription drug monitoring program. They don't really know about all of these broader social forces that are helping to reshape healthcare. But I hope it is also a wake-up call to doctors, that they will say, you know what, this isn't what I committed to do. This isn't what I signed up for. And that they will use that to push back. Because boy, are doctors great at telling nurses and pharmacists that they cannot encroach on their territory.
Yes.
But when it comes to law enforcement, they have a tendency to roll over. And I think that's a mistake.
Right. Yeah, thank you. At DPA, we've been increasingly thinking about the role of privatization in the drug war. And you have this really thoughtful critique of Bamboo Health in your book, which is Bamboo Health is a private company which operates healthcare integration and surveillance software. If you go to their website, it's sort of impossible to figure out what they actually do. It's a lot of buzzwords, but they're deeply involved in PDMPs. So can you talk about the role that you've seen in privatization, healthcare, and surveillance, and how privatization of healthcare or in healthcare spaces impacts patient care?
I think, it's a bigger issue really about public-private partnerships. There's a lot of concern about the privatization of prisons. There's a lot of concern about the privatization of schools. And so we have to ask ourselves if there are some things in our society that we value that shouldn't be vulnerable to market forces. Are there some things that we just care about and should protect? Because if not, capitalism is a hungry institution and it will eat everything that we hold dear and will extract value from everything that we hold dear. And so I think that's what's happening with these public-private partnerships is we've underfunded things that the state is supposed to provide. And then we come in with either a big tech answer or we come out with, a voucher system for schools. And I think that's a mistake. I think we have to recommit to putting money into things that we ostensibly care about, like our schools and our healthcare system. I think the other issue about privatization has to do, one thing has to do with law and one has to do with algorithms. So the law piece is, the PDMP is not an electronic health record. It looks like an electronic health record, but it is not an electronic health record because it does not enjoy the same privacy protections as the electronic health record. Nobody can call law enforcement can't call your doctor and just ask them to hand over your private healthcare record, but they can get that information from the PDMP. So the PDMP is an end run around HIPAA. And I think part of why pharmacists like it so much is because they don't have access to the electronic health record. Certainly not your Walgreens pharmacist or your CVS pharmacist. And so they were flying blind and relying on gut feelings and urge to move really quickly. And now they have at least some information that they feel like they can rely on. But then the piece about the algorithm is when a private company develops an algorithm, it's a black box algorithm. We don't know what's in that algorithm. So your PDMP report is not like your credit score. It's not something that you have easy access to. It's not something you can easily correct. And so, and so especially as PDMPs have gone towards creating a risk score instead of just providing all of the raw data, we don't know what goes into that risk score. And so the shift to more private organizations also constrains transparency. And as people who live in a democracy, we want our agencies to be transparent and we want to know the way that decisions are being made about us. And I think inviting private companies into that space undermines that.
Thank you so much for that. And I'll just uplift a few other, in addition to your book, I'll uplift a few other resources on privatization. One is The Privatization of Everything, which I'm putting in the chat, which is a book by Donald Cohen, which in it he talks about exactly what you're saying of we've sort of cast public goods aside and we don't care about real investments in education and healthcare and public goods. And then Automating Inequality by Virginia Eubanks is another really thoughtful discussion of the role of algorithms and privatization of public goods.
Can I add one to that list?
Please.
Predict and Surveil by Sarah Brain is really good. It's about the use of private technology in law enforcement.
That's great. Thank you.
Yeah,
and we hosted at DPA, my colleagues in the department and also my colleague Melissa Moore, who heads the Office of Civil Systems Reform, hosted a conference on privatization and profiteering in the drug war. And hopefully my colleague Sheila or Melissa can drop that in the chat. We have a ton of audience questions coming in, so I want to move to those and then come back to some final questions. But we have a lot of questions just generally about PDMPs. So I'll ask a few quick ones. So first is, do patients have to consent to their information being shared with PDMPs?
No.
There we go. Are there ways in which PDMPs can be used to help advocate for harm reduction instead of harming in efforts to reduce the overdose crisis?
It's interesting. So the argument that I make in this book is that PDMPs are Trojan horse technologies. They come from law enforcement. They are embedded with enforcement logics, the way the Trojan horse had Greeks inside it. And just because you move it into a healthcare space does not magically transform it into a healthcare tool. Does that mean it can't be used as a healthcare tool? No, it could be used as a healthcare tool. But the problem is that in an effort to curb this crisis, with this mentality that if we cut down on prescribing, we're going to save people's lives, we have handed healthcare providers an enforcement tool and said to them, do with this what you will, instead of wrapping them in healthcare tools that would actually help them deal with the problem. So Lisa, you were bringing up the fact that doctors receive so little education on pain and substance use disorders. I mean, that could be a tremendous way of helping doctors help their patients. Doctors should know how to prescribe things like buprenorphine. We had that X waiver for so long that made it so hard. Now we don't have the X waiver, but still a lot of providers are not inclined to go into that area of care. And so there are ways to use the PDMP medically. And in fact, I've talked to some doctors, some of the most compassionate doctors I talked to still use the prescription drug monitoring program, but they used it as a conversation starter. But they had other tools to help those patients. They would say, okay, well, it looks to me like maybe they have a substance use disorder. I'm going to build their trust, and then I'm going to see what I can do to kind of change their behavior or direct them somewhere else. But that's not what most of the doctors I talked to were doing.
Right. Well, so that's a good segue into this next question. This person asks if you talked to any PDMP planners or advocates in state or federal health agencies and what people thought that PDMPs could accomplish. Did they think it was going to accomplish something, like you said, of like a conversation starter? Or what was the goal?
Yeah, I think it was to make visible. So the healthcare system has, first of all, I did talk to them. And in fact, I talked to people who worked for the PDMP and people who were responsible for the PDMP in state agencies. And so, yes, I don't talk about them as much in the book, but I did talk to them when I started this research. I think that what they're trying to do is make up for some of the lack of communication in the healthcare system. So like I mentioned, pharmacists don't have access to the electronic health record. They only have access to their store's database. So they can see, let's say you work at Walgreens. You can see what a patient has done at your Walgreens. You can also usually see what they've done at any other Walgreens, but you don't know what they're doing at CVS. And so the PDMP does help to create some conversation that isn't happening in healthcare. And then there was a study, I believe it was in Boston, that looked at doctors after overdose. So, the patient is taken to the hospital because of overdose, and then they go back to their life, and their primary care physician has no idea that this has happened. And that's true. There's really limited communication between the emergency medicine physicians and the primary care doctors. And so the PDMP does help bring a lot of that information to light. But I think they also were excited about it because they thought if we could cut down on prescribing, we would also cut down on overdose. And if you look at I have a chart in the book, but if you look at prescribing rates, they went like this, and overdose rates went like this. And this last tail is fentanyl. And so I don't think they anticipated the iron law of prohibition, where you clamp down on something that's safer and you end up with something more dangerous. And that's the space that we're in.